If it is a contact precaution patient,
I already got it, Jen.
what you can do is you can take the glove and put it over your stethoscope and place it in your stethoscope like such, and then listen. That way, your stethoscope won't. Oftentimes, though, when it is a contact precaution patient, there is a disposable stethoscope in the room, so you don't have to use yours. You leave it outside the room. So as I, check my orders, I knock, I verify I'm with the right patient, I foam in, I glove, I'm going to listen to breath sounds. I make sure that the bell of my stethoscope is open to that end, because a lot of stethoscopes have two different sides. Make sure it's open to your end, and you can test that by gently tapping on the stethoscope.
Gently.
Okay, it's loud. Now I'm simply just going to tell the patient I'm going to listen to the lungs. Okay. I'm going to go in that Z-shaped pattern. Listen anteriorly, axillary, and then I'm going to ask the patient if they could sit up, and I'm going to listen to their back. So it's simple like this. So our competency has you listening over the clavicles. There's a apex of the lungs. There's a little bit of lung tissue up here. I'm going to firmly place the stethoscope on the chest like such. I'm going to listen to an entire breath in and out. Yeah. Entire breath in and out. Entire breath in and out. So there's a lot of stuff impeding my lung sounds here. I've got the rib cage. I've got a heart that's making a lot of noise. It's moving a lot of blood. So again, zigzag pattern, Z-shaped pattern. I'm going to listen under the armpits here, and full breath in and out, because at end expiration I can hear those fine crackles. If I remove my stethoscope too fast, I wouldn't be able to hear those. Mm-hmm. So want to make sure you get an entire breath. All right. So now I can go posteriorly, ask the patient to sit up. Again, I'm going to, in that Z-shaped pattern. Listen to an entire breath. If I do hear rhonchi or those coarse crackles, I can ask the patient to cough. And I can also take after that cough and see if it's cleared. Pre-post treatment, delivering in handheld, no. I can also take before the nebulizer. I also take after the nebulizer to see if they're moving any more air. I should have increased air movement and decreased wheezing. I can't hear myself talk. So what I just said is, we're doing these assessments, and we're seeing that if there's a change in respiratory and breath sounds, pre and post bronchodilators, pre and post cough, pre and post mucolytic therapy, pre and post. As you guys saw last night, we have that vest. We can shake people up. We can do some sort of mucus treatments. So a lot of these auscultations, a lot of these breath sounds are part of an assessment to see if the patient is responding to a treatment. So if I hear coarse crackles or rhonchi, I can ask the patient to take a deep breath and cough, and hopefully that rhonchi is cleared after that cough. If I hear very fine crackles in the bases at end inspiration, I can tell the patient to take some deep breaths and do some deep breath holds. Use your incentive spirometer. See if those fine crackles. See if we can pop those alveoli back open so those fine crackles are gone.
What about diminished?
Diminished breath sounds are typically with your hyperventilated COPD patients. There's not a whole lot we can do with that as far as treatment-wise. There are breathing techniques that patients develop, like pursed lip breathing, things like that. there's not a whole lot we can do for diminished. If it's diminished because there's a lack of airflow, an obstruction, we can fix that obstruction. But if it's a COPD patient, emphysema patient with that hyperinflation, there's not a whole lot we can do about that. Again, they have these breathing techniques that they learn as far as pursed lip breathing to help with that. If a patient's squeezing, we're doing a breathing treatment. You come in, the patient's asthmatic and they have expiratory wheezing. We're going to give them a bronchodilator. So we're going to do a pre and post assessment. So in our pre-assessment, we also take expiratory wheezing throughout both lungs. And 15 minutes after our nebulizer treatment, our albuterol treatment, we come back and we note that there's less wheezing. It's not nearly as loud, and the patient's moving more air because we've taken those constricted airways and we've dilated them a little bit. So we're moving more air through those airways, and we have less wheezing. So that's something to note during an assessment. Any questions on placing the stethoscope on the patient? Kind of that Z pattern. We're starting just over the clavicles here, listening to the apex of the lungs, and kind of working in that Z-shaped pattern. Make sure your axillary here are getting under the armpits to listen for those lung fields. And if the patient is able to, we have the patient sit up, because back here we're not fighting with our heart for these lung sounds. You don't hear your heart. You don't get all that vascular blood flow. So this is by far the best place to listen to lungs. You've got more surface area back here to listen to the lungs. Okay? You can practice.